take some time to quantify your setup uncertainty in your clinic based on your immobilization devices. Interesting thing is in the literature you can see that the recurrences that people are finding for IMRT plans are actually in the high-dose treatment regions. It's not at the junction between the lymph nodes and the high-dose region. So we're not missing target, we're just not delivering enough dose there. So with IMRT, we still may be in a region where we're going to look for further dose escalations. And to that end, refinements in the IMRT techniques are still ongoing. And real-time adaptive radiotherapy is still far out into the future. That's still 3, 5, 7 years away where we can do that. So if that's something that you're thinking of waiting for, I think it's farther in the future, and you can proceed with IMRT and still give your patients a benefit of getting as much dose of the tumor and still preserving salivary function and other normal tissue issues. And lastly, these data are taken from a paper published by Mel et al. In Cancer. In 2002, approximately 1/3 radiation oncologists used IMRT. In 2004, that number has gone to 3/4, and largely because implementing IMRT in a community setting is very much a doable thing, and there's a paper published on that by Jack Yang, and that kind of outlines one way to implement that. So with that, I'd like to thank you very much for sticking around. Thank you for your attention, and I'll answer any questions. Is that?
Yeah.
Okay.
Regarding the skin reaction and monitor units, would you please kindly make some comments? Typically, you see on a 7-field head and neck about 1,000 to 1,100 MUs on 6 MV, I have noticed. And then with the 35,